Gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. I've heard from ophthalmologists about the proposed demonstration's potential impact on access to sight-saving treatments for numerous blinding conditions, including age-related macular degeneration, AMD, which is a leading cause of blindness in the United States. Currently, there are 3 treatment options for AMD and other ocular conditions. 2 are name-brand drugs approved for ocular use, and 1 is a cancer drug, Avastin, that is repackaged for off-label use by ophthalmologists for the eye. The demonstration seems to assume that lower-cost alternatives are always available. However, many ophthalmologists are experiencing increasing difficulties accessing the lower-cost drug, in this case Avastin, due to new federal and state regulations on the compounding and repackaging of drugs. Also, notwithstanding the fact this committee worked very hard to allay fears, the fears related to compounding drugs as a result of the New England Compounding Center scandal and tragedy has made many patients reluctant to receive a drug that is compounded or repackaged. Both of these factors are leading to increased use of the more expensive brand drugs. Furthermore, I'm told that the continued access to Avastin for the treatment of AMD and other ocular conditions will effectively end if the FDA finalizes its pending February 2015 draft guidance that calls for a maximum 5-day beyond use date for compounded or repackaged biologics. So I know that it's not directly on point with what you all have been testifying to this morning, and you may not wish to comment on this, but I'm just curious if you all would think that perhaps CMS ought to go back and take a look, instead of including all Part B drugs, if the agency ought to give consideration to excluding certain classes, and obviously the one that I've just talked about are classes of drugs that include compounded, repackaged drugs or a drug that is used off-label for demonstration. So do you think that, and I guess I'll ask you, Dr. Pat, although
sure,
I understand it's a little off your subject area.
Thank you, Mr. Griffith. So I'm not an ophthalmologist, but I will say that there have been discussions of many carve-outs, of carving out oncology, of carving out rural areas, of carving out the oncology care model, of carving out certain segments. In my opinion, there's not a right way to do the wrong thing. We need stakeholder engagement from the beginning to engage with CMS in value-based ways in which we can move forward, like we did with the oncology care model. We want to participate. In our oncology practices, we have many value-based programs and have demonstrated pilots that have saved tens of millions of dollars, and so want to work with CMS on that kind of work. I don't think that there's a way to exclude certain segments from this pilot and make it better. I think that we need to go back to the drawing board and look to projects like the oncology care model that are collaborative and value-based and have a better path forward. We would like very much in the oncology community to participate in that.
Anyone else have a comment on that? Okay. Sticking with you, Dr. Pat, I noticed on page 11 of your written testimony, I didn't hear it in your oral testimony, but in your written testimony you did talk about the era of hospital acquisitions and consolidation in the oncology space, where doctors' practices are being taken over by the hospital, and you think that this experiment by CMS will push more of that, and then that makes it even harder for rural districts like my own. And earlier, one of the folks said they had a rural district that had 19 counties. I have 29 geopolitical subdivisions, most of whom are rural counties.
Yes, sir. So as we mentioned, the current model, which is not really ASP plus 6 because you have to take out prompt pay, sequestration, and the 6-month lag, has to take into account not only acquisition, but also inventory storing of drugs, specialized handling of drugs, and then disposal of drugs. So there's a lot that has to go in there. If you bring it down to ASP plus 0.86%, you have to know that average sales price is by its very nature an average. There are people that pay more than that average and people that pay less than that average. Hospital systems and large practices are going to get preferential contracting to pay less than average on average, and smaller practices are going to have less bargaining ability because of less volume-based purchasing and have to pay more. So you can imagine if you're at ASP plus 6%, it has to pay for all of these other functions, and you're paying 1% higher. How will you be able to keep your doors open? And so what we've seen with these financial pressures over the last decade is the natural consequence of the shift from community practices to the hospital outpatient department. And we know that that's a 30% shift in the last 11 years. We also know that that conveys on average a higher cost of over 30% and a higher copay for patients. And again, if we look at the cost of that shift in 1 year for cancer spending, just attributed to the distribution of site of service alone, it's about $2 billion.
All right, I do appreciate it. Thank you very much, and I appreciate all of you being here today. Yield back.
Chair, thanks, gentlemen, and now yields 5 minutes